I won't take up much of your time for the sake of time, as we said earlier. So I'll give you some brief, some cases that I've seen recently with regards to the use of vestibular migraine potentials to try and emphasize some key points with regards to using vestibular migraine potentials in helping in the differential diagnosis of patients with dizziness / vertigo. So the first case here, I label here as a neurological application, or this is, but this is not necessarily a neurological etiology. I name it as such because this patient was referred to us from my neurology colleagues. This is a patient being followed for epilepsy. But she presented with vertigo and imbalance for 2 weeks prior to seeing us. The clinical examination was negative for positional nystagmus. The patient was already taking valproic acid for her epilepsy and also stemedil and beta-circ to control the symptoms. And the referral letter wrote that we needed to rule out vestibular migraine for this patient, although when asking the patient directly about her symptoms, she did not mention anything remotely related to migraine, either in the form of headache or photophobia. So I was already doubting before doing the VEMPs that this patient had vestibular migraine. So the reason I'm presenting this case is to emphasize the usefulness of vestibular migraine potentials, perhaps in difficult cases, to differentiate between vestibular migraine and Meniere's disease, which both can present with episodes of vertigo. So we've said this several times during this Congress, where Meniere's disease is a clinical syndrome that consists of episodes of spontaneous nystagmus, usually associated with oral fullness, tinnitus, and sensorineural hearing loss. And it's thought to be associated with the accumulation of endolymph in the cochlear duct and the vestibular organs on histological examinations. And we also have vestibular migraine, which is also associated with episodes of vertigo with or without migraine. However, the episodes of vertigo, by definition, especially by the Bharani Society, are usually coexist with separate episodes of migraine without vertigo. The cause of this clinical entity is unclear, but as we said, has been emphasized in previous talks, it's a mixed disorder. There can be some central components and some peripheral components as well. There was one study that indicated the presence of endolymphatic hydrops in both ears, but this study was not replicated, so we're not sure about this. So like I said, the emphasis here is to differentiate between Meniere's disease and vestibular migraine, and it can be difficult to differentiate between the two. The reason is that tinnitus, which is associated with Meniere's disease, can also be associated with vestibular migraine in some cases. And also migraine that you see in vestibular migraine can also be seen in some cases of Meniere's disease. And in fact, to make things more difficult, some patients can have both Meniere's disease and vestibular migraine. So it can be difficult in some cases, especially in the hands of those who may not be so experienced in neurology, to differentiate between whether the patient has vestibular migraine or Meniere's disease. So, a paper published in 2011 by Taylor et al., which includes Michael Hamagi in the group, helped to develop a protocol to help differentiate between the two disorders. And what preferentially agrees with Meniere's disease rather than vestibular migraine depends on 3 signs according to the paper, which appears to be valid. One is an asymmetry in the C-VEMP response. So if you find an asymmetry in the vestibular migraine potential with one ear involved preferentially with respect to the other, this tends to indicate Meniere's disease rather than vestibular migraine. In other words, to think of Meniere's disease as an asymmetric disease, whereas vestibular migraine tends to be more symmetrical. Also, this becomes more valid if you combine this with an asymmetric caloric response. So if you have an asymmetric caloric response and an asymmetric VEMP response, then this suggests Meniere's disease. And on top of that is, if you remember yesterday with regards to my talk on the protocol on how to perform CVEMPs, one preferentially uses a tone in frequency of 500 hertz. This is an example of a case where, dependent on the differential diagnosis, to change your protocol to better answer why the patient is being sent to you. And in this case, when there is a suspicion of either Meniere's disease or vestibular migraine, and this is what I do in my laboratory, is to do the CVEMP also at 1 kilohertz. And the reason we do this, we do the study both at 500 hertz and 1 kilohertz, and I will show you now some examples of this, is to demonstrate a frequency tuning or frequency shift. CVEMPs are best obtained at 500 hertz, but if you find a better response at 1 kilohertz instead of 500 hertz, this suggests endolymphatic hydrops. And I will show you some examples now. So we go back to the patient that I presented in the beginning, a 41-year-old, vertigo imbalance for 2 weeks with a history of epilepsy. She was negative for the Dix-Hallpike maneuver. She was ruled to us to rule out vestibular migraine. Her pure tone audiometry examination was within normal limits bilaterally. So the audiometry appears to rule out Meniere's disease. And this is an example of a CVEMP examination. This is an examination at 500 hertz, the protocol that I recommended yesterday that you do with regards to cervical VEMPs. And despite this asymmetry of the CVEMP, combining it with the EMG, like I emphasized yesterday, it's a normal result because the amplitude ratio between the CVEMP and the EMG is symmetrical and normal. So at 500 hertz, the CVEMP was normal. However, I demonstrate here in this case, and I will show in the next slide, like I mentioned in this case, there was no mention of migraine. I did this examination at 500 hertz and 1 kilohertz. And what you can see here is that the amplitude of the CVEMP response is larger than at 500 hertz. And even combining it with the EMG and obtaining an amplitude ratio, this asymmetry still stands out. So in this case, we have an increase in amplitude of the CVEMP response at 1 kilohertz compared to 500 hertz in this patient, suggestive of the presence of endolymphatic hydrops in this patient, and ruling out the possibility of vestibular migraine. However, in this case, as I mentioned earlier, the audiogram was normal. So by definition, this would tend to rule out Meniere's disease, because in Meniere's disease, you would expect a low-frequency hearing loss. So this tends to rule out Meniere's disease, or at least an endolymphatic hydrops involving the cochlea. I recommended that a caloric test be done for this patient as well to look at the vestibular apparatus in more detail, because as I mentioned yesterday, you should not look at each paramedical examination in isolation, but put it all together as a test battery. But my impression here, which I gave to the referring physician, is that because we had a frequency shift, at least for one ear, in the presence of a normal audiogram, that we may possibly be dealing with endolymphatic hydrops involving the right ear, but involving the vestibular labyrinth. So the possibility that we have endolymphatic hydrops not involving the cochlea, the audiogram is normal, but endolymphatic hydrops involving the vestibular labyrinth. And this is something that has been described recently in some recent papers and has been called recurrent peripheral vestibulopathy to differentiate it from Meniere's disease. In other words, the possibility that you may have patients, and this was helped with the use of vestibular evoked myogenic potentials in this case, that you may have a patient with endolymphatic hydrops, but involving the vestibular labyrinth and not the cochlea. So I'll give you another case as well, a patient or a 56-year-old female with probable Meniere's disease. I haven't seen the pure tone audiometry yet with this patient, but she reported the pure tone audiometry to be abnormal with regards to the left ear and showing low frequency hearing loss. And I did the examination using both 500 hertz and 1 kilohertz. The left ear, which supposedly showed the abnormal audiogram, shows a response at 500 hertz, which was not better at 1 kilohertz, the ear which had the abnormal audiogram. But doing the other ear, the right ear, which had the normal audiogram, the response with regards to the CVEMP was larger at 1 kilohertz than at 500 hertz. So a frequency tuning shown with the use of CVEMPs in the ear opposite to the one where the audiogram was abnormal. So what does that tell us? Perhaps in this case, and I don't remember reading this in the literature, and we may report this, is that we may be dealing with a case of bilateral endolymphatic hydrops, but affecting the cochlea on the left, where the abnormal pure tone audiometry is, and affecting the sacral on the right. So bilateral endolymphatic hydrops affecting different parts of the labyrinth in either ear, which is something very interesting. And it begs the question also that if you decide to take this patient to do intratympanic steroid injection, should the symptoms persist, would you do the injection on the left where the audiogram was abnormal, or would you do it on the right where the CVEMP was abnormal? Someone who did not do a CVEMP, who would not have done a VEMP in this case, would probably do the injection on the left. But having done the VEMP, perhaps you would reconsider this and do the injection on the right. Okay, so this is which is something I found interesting and perhaps goes towards using vestibular migraine potentials in such cases. And in fact, what I recommend, and what I do routinely, is that if you have a patient being referred to you for either vestibular migraine or for Meniere's disease, or the referring physician does not know what the patient has, but asking the question yourself directly, you get the feeling that perhaps we may be dealing with Meniere's disease, to do your cervical vestibular migraine potential not only at 500 hertz, but using 1 kilohertz stimulation as well. So adapting your protocol dependent on the differential diagnosis, or perhaps the differential diagnosis that you create after asking the patient. So coming towards the end of my talk, I will describe one case here of a possible central cause of vestibular dysfunction, possible because the patient has not done the MRI yet, but this is an interesting case. This is an 84-year-old lady with long-standing feeling of non-specific vague dizziness, though she did report 2 spells of rotatory dizziness about 40 years ago. Her air calorics or caloric stimulation revealed diminished responses bilaterally. So the caloric responses were abnormal bilaterally. And the patient was referred to us to rule out a bilateral vestibulopathy. And in fact, the referring physician, an ENT colleague, made it known to me that perhaps he did not believe that the patient did have bilateral vestibulopathy because she did not have the typical symptoms like oscillopsia. So this is a case I showed yesterday of related to the age-related changes in VEMPs. This 84-year-old female, again, I emphasize the beautiful nature of these VEMP responses, even at this age. So you should not be afraid to do VEMP responses in the elderly population, and you can get these beautiful responses. One important fact here is that, as you know, the caloric response the response along its pathway includes the superior vestibular nerve. We have here the ocular VEMP, or ocular vestibular migraine potentials, which also includes the superior vestibular nerve. So we have abnormal caloric responses bilaterally, but normal OVEMPs bilaterally. So if we take these results at face value and believe that perhaps we are not dealing with superior vestibular dysfunction or inferior vestibular dysfunction. In other words, we are tending to rule out a bilateral vestibulopathy, agreeing with the clinical suspicion of the referring patient. What we are probably dealing with is isolated horizontal canal dysfunction. Possibly. I haven't confirmed it, but when you have abnormal caloric responses bilaterally and normal CVEMPs and normal OVEMPs and the clinical suspicion that the patient does not have bilateral vestibulopathy, perhaps we are dealing with isolated horizontal canal dysfunction. And is this possible? Yes, there are references in the literature that you can have isolated horizontal canal dysfunction. And when you do have such cases, you should recommend a brain MRI because there are certain brainstem lesions that can affect the vestibular nuclei in a specific way to cause isolated bilateral horizontal canal dysfunction. We did ask this patient to go and do a brain MRI, although she elected not to do so. So I cannot confirm that the patient does indeed have this, but the reason I show this case is to emphasize this possibility that you can have certain cases of focal brainstem dysfunction that can appear to give the impression that you may be dealing with peripheral vestibulopathy. And this is one of these excellent publications, including Michael Homagyi, illustrating the fact that you can have central symptoms with selective semicircular canal involvement that can mimic a bilateral vestibulopathy. And according to this paper, the specific lesions that can cause or give the impression that you are dealing with a bilateral horizontal canal dysfunction are acute floccular lesions, vestibular nuclear lesions, involving the inferior cerebellar artery as well, although there are reports of isolated bilateral horizontal canal dysfunction in Wernicke encephalopathy. I did recommend thiamine levels to be measured in this patient as well, and I'm hoping to see the results of that. So it's not possible to present all possibilities of the clinical applications of VEMPs here. The list is almost endless, and I did not want to tie, of course, with an endless list of cases. We are in the process of writing a review we're together with Dominic Straumann from Zurich, and we hope to have it published before the end of this year, looking at the clinical applications of both CVEMPs and OVEMPs, and it is in fact a very long paper emphasizing the fact that there are many clinical applications where VEMPs can be useful. Of course, I cannot illustrate all these cases here. However, if you do have cases in the future that you would like assistance with and you might want my advice with regards to whether VEMPs can be useful for you or not, this is my email here, and you can send me an email and you can send me your waveforms, and I can give you recommendations on how to interpret your VEMP responses with regards to your differential diagnosis. And finishing up, I'd like to thank my colleagues for help with the figures, Ms. Eleni Polikarpou, and also my colleagues from ENT, Marios Tabis, and Savas Papakostas from Neurology for providing me with the patient referrals. Thank you.